Of everyone, and this is going to be recorded. And this is, CME certified, endorsed by American Society, and supported unconditionally by MPS. Thank you very much for your attendance. I think we have around 120 registered for tonight. Cardiovascular protection. I'm sure all of you hear about, the leading world cause of death is cardiovascular, around 21 million. And the leading reason for that is risk factors, is high blood pressure. And we try in UAE to unify and to have a strategy for that, inshallah, to able to control this through at least 8 societies for that. And tonight we're talking about major risk factors, hypertension, and the leading, if we don't do that properly, of course, lead to the stroke and lead to the cardiovascular events, MI and the rest. And then there are another problems, atrial fibrillation, which you all know. So both of these need attention, need to have more aware about it. So first speaker is Professor Samer Laham. And he's a professor of cardiology, cardiovascular medicine in Cleveland, Abu Dhabi. In addition to that, he's a man of quality of cardiac health. He's, any talk you will see, try to raise not just people to be aware of how to implement that and how to bring the guidelines into the practice. So his talk about not only hypertension and the guidelines and getting the target is beyond that, to protection. He will talk to us about that. Then we'll go to Dr. Hani after that. So, Professor Samer Laham, are you ready for the talk?
Thank you very much, Dr. Abdullah. It's a pleasure and honor to be with you and my dear friend and Dr. Hani. So I'm just going to share my slide. And thank you for the kind introduction, as always. Okay, can you easily see my slide?
Yes.
Okay, can you hear my voice? Am I clear?
Very nice.
Okay, so we have a very important topic. It's hypertension. السهل الممتنع. It sounds very obvious and easy, but I think I'm not aware of anything more challenging than the two topics. One is hypertension, and the second one is non-valvular AFib. So I'm going to be talking about hypertension. I'm going to be giving quite a few tips and my humble experience in this. And we would love to have an interactive session at the end with questions and answers. So hypertension prevalence and statistics. This may sound like a broken record. It's actually not. Who would believe that 1/3 of the patients, 1/3 of GCC, 1/3 or 3 out of 10, if you want, you can do it any way you like, has significant hypertension defined as greater than 140/90. And we can discuss later what is the exact definition of hypertension. And the control, for whatever reason, and we will discuss, is still miserable. And there is no other way to say it. Almost 50% are either not controlled at all or poorly controlled. And what is amazing about this is it's very complex. So if you go to countries where everyone is insured, very high education, better, health literacy high, same thing. It's almost always the same number that we are quoting. And we'll talk more about this in a second. So the reasons are quite a few. Adherence is a problem. You could say that it's asymptomatic. Patient take medications, occasionally cause side effects. Why take it? Treatment does not lower the blood pressure appropriately, and we'll discuss this more. Absence of synergy between the treatment and the very difficult, challenging, the clinical inertia. The whole idea that for some reason people don't want to push more. They just stop. And we see this in heart failure. We see this in atrial fibrillation. We see this in hyperlipidemia. We see this everywhere. So this is not only in this chronic disease. So what are some of the potential solutions? One of them is kind of an interesting one. It's called the rule of 10. And I'll read it, then I'll show you. I've made some slide on this to clarify this for you. Determining the number of medications needed to reach target blood pressure from either the first or the second or maximum the third visit if you're not even sure the patient has elevated blood pressure, hypertension, or the like. And the approximate number of the medication is the current blood pressure minus the target. So, for example, if it's 170 and I want the systolic blood pressure to be 130, then obviously it's going to be 4. So I'll give you an example that I made for you. So if the current blood pressure of our patient in the clinic today is 170, and the target, which is true in many cases, let's say he's diabetic or has any other problems, CAD, etc., then the difference is 40. So 40 divided by 10, 4 treatment steps on medication adjustment may be required. Now, this does not mean we for sure need 4 different medication. It could be that we need combination therapy. It could be that we need to escalate the combination therapy as dosage. It could be that we need to optimize lifestyle even more. It could be that we need to add additional agents. But in general, it's a rule that works many times. There are obviously exceptions for every rule. Why this matters? Because severe hypertension is rarely controlled with one drug. That's a fact. Rarely, never. I should say never. Delaying escalation leads to persistent uncontrolled blood pressure. In the modern guidelines, we are focusing now more on faster blood pressure control, early combination, and avoiding therapeutic delay. So a key principle, and I like this, yellow principle. If blood pressure is far from goal, treatment intensity must match the degree of elevation. So someone comes with 170 and we give them, say, a single therapy with low dose, it's literally impossible that we will get to goal, and that's the inertia. So inertia is not only not to treat, but not to treat appropriately or intensively. Another thing which is very important is, and this needs to be kept in mind, some caveat. This is not a strict formula, obviously. We need to be careful about age. If patients are above 85 or sometime 80 or 90, we need to be more careful. Frailty, and we can discuss about this. CKD patient, diabetes, heart failure, CAD may have special needs, drug tolerability, volume status, and obviously the secondary hypertension. So my message is treat the patient, not the number. This sounds obvious, not many times. I see several patients where colleagues, respected colleagues, for some reason were more following the blood pressure and the patient had additional issues. The example here is also to illustrate this concept in a different way is the uncontrolled hypertension. If you double the dose of a medication, typically you're likely to decrease the blood pressure by around 2 millimeter of mercury. This is systolic, I'm talking. Addition of another drug, and obviously it can vary, but in general, typically lowers by around minus 10 millimeter of mercury. And I will show you in a second that 10 millimeter of mercury is a very, very big deal. 10 millimeter of mercury is a huge, huge impact, a positive impact on the risk of the patient. So again, my usual words of wisdom, adding another mechanism is usually more powerful than pushing one mechanism harder. I think my slide speaks for itself. So low treatment adherent among hypertensive patients, are you surprised? Again, very high number you can see in the slide, especially if they are less than 4 years. This sounds like a broken record. We heard it, but it really shows you how much we have currently challenges. I will be talking about the guidelines, and Dr. Abdullah Shahab mentioned it, but the guidelines keep on getting more strict and the gap keeps on getting greater. So I call it the guideline real practice chasm شرخ بالعربي, and we can discuss this at the end. So the initial treatment with a single pill combination, again, improve treatment adherence and better time to achieve the target. And the numbers speak for themselves, and these are the references. So in general, with the exceptions of frailty and few other things I told about, older patient, etc., it's typically wiser and more supported by the guideline to start with 2 lower with different mechanism than to push one for the obvious reasons that I already mentioned. Initial treatment with single pill combination for improved outcome. Again, this slide summarizes many, many ideas, but basically you're talking about 20 to 40% decrease of cardiovascular event and the risk of ischemic heart disease. So the numbers speak themselves. It makes more sense. It is more adherence. The guidelines support it. and inertia need to be discussed. So again, my word of wisdom, start effectively rather than escalate slowly. So I think the messages hopefully are clear. Would love to hear from you at the end if this is your experience. The second component is hypertension and the risk of cardiovascular disease. So, as you know, cardiovascular disease is a spectrum, whether we talk about myocardial disease, ischemic heart disease, electrical disease, valvular disease, all of them. And intervening at any level is highly recommended. But the sooner, the better. The more, the better. The wiser and smarter, the better. And that is the simple message of this slide. So clearly, we want to interfere early on. So the cardiovascular disease is the leading cause of death. I mean, we spoke about it so many times that I think when you hear it, you feel almost disconnected. I mean, we know it. But clearly, what we need to do about it are quite a few things. One of them is to control the hypertension and keep it as a risk factor, not to create diseases such as ischemic, cardiomyopathy, or other problems that you are aware of. The leading cause of death, I said, is cardiovascular disease, and we're not going to reinforce this anymore, but this is where the matter. This is where the substance is. I mean, when I look at the slide, I say, how could there be inertia? I mean, seriously, how could you, Samer, how could anyone have inertia? The relative risk of death, hard endpoint from ischemic heart disease and other vascular causes doubled with each increment in the blood pressure 20 over 10. So systolic 20 and 10. And you may say, wow, that's a lot. You have no idea how many times you and I see patients where this is the case. And you could see that if we lower the blood pressure, that's going to be the reverse. And you can see how starting with 115 over 75, you go up to 175 over 105. You're talking about eightfold increase. Ridiculous. Sure, eightfold. This is, absolutely, I mean, isn't this negligence? I don't know. So this is obviously unacceptable. And each 10 millimeter of mercury increase in systolic blood pressure, 45% ischemic, 65 stroke. And again, I'm not going to kill you with the same topic, but I mean, you could see from 20%, 17, 28, 13, 27. You could see heart failure and stroke. Wow. Major cardiovascular. Wow. But everything else. And we're not even discussing AFib, which my dear friend and colleague will discuss, and many other electrical arrhythmias. Just a comment, I'm not going to go over the slide. This needs a whole grand round, but there is a concept of blood pressure variability. So while heart rate variability is very good in general, with few exceptions, blood pressure variability is not very good and is concerning unless you're talking about the daily one. So if you're talking about daytime, and then the drop at night, which should be 10 to 20%, then that is very favorable. But if you're talking about the different one, the very short one, which I described here, and then the short term, the mid-term, and the long term, there are significant data that the patient is likely to have more stroke, more dementia, more heart failure, more ischemic heart disease, and more kidney disease. And that is something very concerning. I'm not going to take too much time on this, but this needs the whole topic. The reason why I show you this comes very, very closely with my research interest, which is cuffless blood pressure measurement using AI and using algorithms. And not to take too much time from the audience or from the next speaker is there is whole science behind this. And there are different mechanisms addressing this. But suffice it to say that a long-acting antihypertensive agent is more favorable for many reasons. One of them is addressing blood pressure variability. How about the guidelines? I'll be very brief about the guidelines, and I'll try to focus on what I think really matters. So these are the European one. What's the message of the slide? Quite a few messages. Number one, that the office one, the normal is totally different from the home one. the daytime and the ambulatory 24-hour blood pressure versus the nighttime. And I'm not going to ask you to look at these, except look all the way down to hypertension. Look at the office one. If we define it greater than 140 over 90, obviously it depends on the risk. And that's what Dr. Abdullah was trying to address, bringing up how it's important not to treat the blood pressure, but also how you treat it and what are the risks. So obviously, like the hyperlipidemia, if you have a very high risk, we may aim at 1 or 1.4 millimole per liter, if not maybe 3. Same with blood pressure. But assuming that we're defining blood pressure, hypertension as greater than 140 over 90, you could see the significant differences of the numbers. And that's very important, and especially for people who read these things. This is a very interesting slide from the European Society of Cardiology, and it first starts by saying that, again, what I mentioned before indirectly, initial monotherapy is okay per the guideline if the blood pressure elevation is not very significant. So we're talking about either borderline elevation or we're talking about stage 1 hypertension. If there is moderate to severe frailty, and we can spend hours on defining frailty. Frailty is not only you look at the patient, but how active they can be. And there are grip tests and many other ways to define frailty. Many people just look at the patient and call them frail. 9 times out of 10, you are correct, but there are more objective methods. One of them is, we can discuss later. Symptomatic orthostatic hypotension, which is not unusual, and patients who are 85 or greater. Otherwise, they immediately talk about low dose double combination therapy. So remember low dose, remember combination therapy. And they talk about ACE inhibitors or ARBs with the favorable calcium blocking agents or diuretics. So that is for the class 1. As you go down, the patient comes back, it's controlled within 1 to 3 months. Good news. Patient is not controlled, then you go to the next layer, which is low dose triple combination. Interesting. So again, low dose triple. So we're going horizontal instead of vertical. Controlled, then you can see the patient, according to them, at least every year. I mean, typically you and I would see every 3 to 4 months, probably 3 months. And then we go all the way down. If the patient is not controlled, then you go on the maximally tolerated doses of the triple therapy. At any of these stages, if there is a compelling indication, then our friends, the beta blockers, will be added, but they are number 4. I say our friend because in cardiology, like some of you and other specialties, we use it, but clearly it's number 4 as a choice. And again, I showed you this before, but just to reinforce the slide, there are some groups where the guidelines recommend to start with a single therapy. They don't have to be old. If the blood pressure is slightly elevated and consistently mildly elevated, then you can start with one. In addition to guideline-driven lifestyle changes, the DASH diet, which is the dietary approaches to stop hypertension. As you know, there's an app for it in different languages. And the latest, again, the international guideline, again, I'm not going to take time on this. It's the same concept, okay? So I'm going to fly through the slide because I just want you to focus on the concept. This slide is very important because from the AHA and ACC, this is from a few months ago, we need first to define what hypertension is, right? So hypertension, at least in general, according to the American guidelines, stage 1 is 130 to 139 over 80 to 89. And I think this is important for us to keep this in mind. How to take the blood pressure, I'm not going to go over this, but this is not for us or our nurses. This is what we need to tell the patient. And trust me, we need to spend 5 to 10 minutes just describing this, or maybe the nurse can do it. Or the best way is tell them to bring their device. You can compare to our hospital or clinic blood pressure, and you can check how they are taking their blood pressure. Again, same story. Is it office? Is it home blood pressure? Or is it 24-hour ambulatory blood pressure? And basically, there are 3 key messages in these guidelines. Number 1, in adults, it's highly recommended that we either do 24-hour blood pressure or home blood pressure. Message number 1. Number 2, it's very important when they are taking their medication to keep that in mind and make sure the interventions are being followed. And number three, important topic, cuffless. I'm sure patients ask you about this. Means the electronic devices where there is no inflation. Convenient, but unfortunately not currently recommended per the guidelines. Lifestyle changes, I'm not going to talk about it, but please keep in mind one thing they are missing, dietary intake and non-dietary. What is missing? I'll give you 1 second, 10 seconds, 15 seconds. Smoking. So AHA, ACC guideline, I must be missing something, but they are not mentioning smoking, which obviously is a risk factor. White coat and mask. White coat when you come to the clinic, mask at home, higher. And these are the things. I'm not going to go over them in detail for you, but please, as a reminder, there are very clear recommendations on how to control blood pressure with diet and lifestyle. So please keep this in mind. These are cornerstones. And again, they go over this, and you could see how the guidelines go. The method is very similar, except that they talk about something very important, which is the prevent cardiovascular risk. So I thought I'd just show you briefly. I made some slide on this. It's the modern AHA risk assessment tool. It includes risk of heart attack, stroke, heart failure, cardiovascular death, and supports obviously preventive cardiovascular management. So it includes age, sex, blood pressure, antihypertensive treatment, cholesterol profile, smoking, very important, diabetes, kidney function, body mass index, and obviously it's a very important risk, and it's been discussed in several areas by the American guidelines. So when they say that prevent cardiovascular disease risk is 7.5% or greater, it suggests a very, very high risk. That's the whole idea when we talk about the guideline. So again, these are the recommendations from the American. I'll mention them very briefly. Stage 1, class 2A, initiate a single first-line agent is fine. Stage 2, initiate 2 first-line agents of different classes. And any stage or 3, don't combine ACE and ARB or renin inhibitors, and obviously we can go on and on. And this is at least indirectly from the on-target data. And again, they make recommendations on how to improve adherence, which I think is very important. I think I left my phone far. I'm not going to leave it and get it. Okay. Now we go into telmisartan, and we would look at it as a model for lowering blood pressure using medications. I'll be very brief and I'll focus on what I think is important. The drug is lipophilic, so the half-life is long. So we have the data showing this very clearly. And then there is a high receptor affinity, which you could see compared to the other Rs. The interesting thing is this slide, highest selective PPARY activation. So what is that? At least theoretically, it's something very interesting. It's the peroxisome, trust me, I won't remember it, I wrote it. Profilator activated receptor gamma. It's a nuclear receptor involved in insulin, sensitivity, glucose, lipid metabolism, adipose biology, inflammation modulation. Wow, all what we worry about. And basically, theoretically at least, it's a very favorable metabolic aspect of this ARB. Again, if we look at the drug, it has a large volume of distribution. It has the shortest Tmax, longest half-life over 24 hours. Remember the variation I told you about. Does not metabolize by C450, no active metabolites, and the least renal excretion because it's lipophilic, so it's less than 1%, which is more convenient with patients that you are worried about their kidney function. And this is a slide showing that there is practically no need for dose adjustment in patients with kidney disease, at least when we talk up till 30. Again, a very interesting thing, which is we spoke about adherence, we spoke about compliance. Since this medication, this ARB, it has a long half-life, it's likely to maintain its effect even if the patient missed a dose. This is obviously not to encourage missing dose or to promote missing dose, but if this happens, let's say that's more forgiving. Now, interesting concept is ARBs in cardiovascular outcomes. For the younger doctors, you may not remember this, but for some of us, because ACE inhibitor have other methods where they may benefit, like some people said, oh, bradykinin actually, although it causes angioneurotic edema and maybe causes cough and maybe causes other things directly or indirectly, but they also have a beneficial effect. And we need proof that the ARBs have favorable cardiovascular outcome. I will be discussing Transcend and on target, but very briefly to summarize this, the at least telmisartan was found compared to ramipril, the drug of the HOPE trial, to be non-inferior. So it was a non-inferiority trial, which I will show you in a second. And this is important because while the number one focus is safety, tolerability, adherence, addressing inertia, and lowering blood pressure to goal, no question about those. But the second layer, the third layer, and more, we want to look at the outcome. Remember, if the output is lowering blood pressure, we'll look at the outcome. That is not to say that other antihypertensive agents do not favorably affect outcome. That is to say that in this case, with telmisartan, for example, as NARB, the outcome is remarkably favorable as a drug that you know, which is ramipril, which I'll show you the slide in a second. And this is just reinforcing the same message. I'm not going to take too much time on this. So now we'd look at a series of trials that looked at this very important aspect. Don't want to really take too much time on this. I'll focus on the trial. If I had a show of hand, I'll ask you if you know the on-target trial, and I think almost all of you know it, but I will briefly summarize it. Then I've made some slide to make it clearer and to summarize all the slide at the end in case you missed it or fell asleep, God forbid. So the on-target. International UAE was one country that was involved in on-target. The on-target had this randomization pattern with a large number of patients, and Transcend, which I will discuss in a second, had also a reasonably good number randomized. The outcomes that were looked at are the hard important outcome, cardiovascular mortality, non-fatal MI, admissions for heart failure, and non-fatal stroke, the bad ones. The inclusion criteria are the high-risk patient, basically, very high risk. CAD, PAD, CVD, CVA, diabetes mellitus with end organ damage. So the inclusion criteria were very strict and clear. The ages are in the 66, 67. You could see the level of the blood pressure, elevated, but not extremely elevated. You could look at other things if you are interested, but very importantly, high prevalence of MI, stable angina, diabetes, etc. If I had 1 hour, I will discuss the on-target by itself, but I'll be very brief so we can focus on what we want to discuss and give time to my colleague. These are the drugs, ACE inhibitors, ARBs, beta blockers, diuretics, nitrates, calcium blocking agents, antiplatelet, oral, anticoagulant, and statins. So this is how they were randomized: telmisartan 80, ramipril 10, and then combining an ARB and an ACE. So some of you would say, what? ARB and ACE? I assure you that professors and very, very good ones in the United States were doing this routinely, and some of them are even put questions for the board of cardiology in heart failure patient, and not occasionally, rather frequently, sometime for patients with hypertension. So this was a very valid question and important. So very interesting. Compared with ramipril, there was a very good outcome result, but this slide summarizes what I really need to discuss with you. This is called a non-inferiority result. So ramipril, the very established one for outcome from the HOPE trial. I mean, for 15, 20 years, all what I could hear is hope, hope, hope. was compared to telmisartan, and this is considered very favorable. Please remember, this is 80 milligram of telmisartan with 10 milligram of ramipril. So this is the key message with very good outcome. So it got it, obviously, the cardiovascular prevention indication per the strict regulation and the rules of the FDA and also of the European Union. The other trial is the Transcend trial. Again, telmisartan versus placebo. I've shown you it's around 6,000 patients. Here we're looking at patients who were intolerant to ACE inhibitor. And these are not few. In the United States, in some subgroups, especially females from a certain race and gender, this could be up to 20%. And men of some race and gender and some race, again, very high. So this is not uncommon at all. And when you look at the risk, again, the same story in hypertensive patients, but not in non-hypertensive ones. It showed 27% risk reduction in MI compared with placebo. So if you look at the right side, these are the hypertensive patients. If you look at the CI, at the confidence interval, you would see it didn't cross 1 with a p-value of 0.02, which means it's very significant. For the non-hypertensive, it was not. And again, interesting data regarding LVH and others. I'm not going to really spend too much time on. I'm getting very close. I probably need 7 minutes. Renal protection. So if I was in a room and I had with me all my respected colleagues, and I would ask 3 questions. I would say, when was the last time you ordered urinalysis, especially for cardiologists? No offense. Second one is urinary albumin excretion. I'm sure Dr. Shab and Dr. Sabur would say yes because they do it. But I'm just telling you as a reminder. And number 3, are we relying only on creatinine to assess kidney function improvement, etc.? So that's a completely different story. The renal outcome were very briefly favorable, as you can see with the p-value, and that adds even more important aspect. But I really want to stop here for a second with the permission of Dr. Shahab and say that it is so important not only to look at creatinine and potassium, which is very important, but also urine albumin excretion should be part of our clinical blood test that you check, blah, 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 like the lipid profile, like the other thing, just as a humble reminder. And again, more effective than losartan, the first ARB that came to market. Single pill combination, again, the European guidelines and the American talk about which one are the most favorable. And for the ARBs, it's been very consistent. Dihydropyridine and diuretic, in 2 words. And the nice thing about this is the edema thing. So as you go to an amlodipine 10 milligram, not a bad percentage, it varies a little bit, 10, 15% more or less, depending on the patient, your population, they may come and tell you about different levels of edema. Now, the edema is most of the time not clinically relevant, but inconvenient for the patient, can make them stop the drug. So it's very inconvenient for the patient and the doctor indirectly. And the mechanism, I think we all know it, which is the vasodilatation versus what the RAS inhibition does, leading, I will tell you, I rarely see an ARB with amlodipine causing edema. I don't remember having this at any time. And this is Twinsta, which is the telmisartan with the amlodipine. So now we have 2 long-acting. Telmisartan, a very solid 24 hours. Amlodipine, a very solid, depending on the studies, 28 to 32 hours working together. And not surprisingly, when you look at the drop of blood pressure in diabetic, obese, metabolic syndrome, my favorite topic, elderly, our respected Black colleagues, and then severe hypertension. And the average is huge, 40. Remember the slide I showed you. Please remember the slide I showed you and imagine the systolic blood pressure decrease in 40. So this is 220. Huge, huge outcome data. And this is again the benefits getting to goal, much, much higher. So I'm not going to really take more time on this, and less peripheral edema. Okay. Now, my final words of wisdom. So I put together a few slides kind of summarizing everything. And I want to thank again Dr. Shahab, the organizing committee, and my dear colleague, Dr. Hani Sabur. Key practical takeaways on target. Telmisartan is very similar to ramipril when it comes for major cardiovascular protection in high-risk patients. So we call it non-inferior. Message number one. Message number two, transcend. Telmisartan beneficial in ACE intolerant high-risk patients when they are hypertensive. I've shown you the data. Dual RAS blockade, which is ACE inhibitor and R, more adverse effects, no major outcome advantage, generally avoided. So the guideline call it class 3, so out. I hope this summarizes everything. Hypertension drives progressive cardiovascular damage, leads to what you know, CAD, MI, heart failure, stroke, CKD, etc. Early intervention is very beneficial, and I recommended it many times. The European guidelines, early low dose combination, single pill combination improves adherence. The rest, I think, we already discussed several times. I also mentioned the home blood pressure and the ambulatory one to be reinforced, and the strong cardiovascular outcome evidence with telmisartan. The strength of telmisartan is the long half-life, strong 24-hour blood pressure outcome data, well tolerated, and for patients who are ACE intolerant. The message at the end is treat early, avoid clinical inertia, think beyond blood pressure, and very importantly, use different mechanism. This is a slide that we all see every day. This is a slide we all see every day. Heart attack should be prevented very early, and then our Chinese colleagues come in. This is a slide from 3,000 years before BC or 2600. It says that superior doctors prevent the disease. With this, Dr. Shab and Dr. Sabur and organized committee, I thank you very much for your attention.
Outstanding as usual. I promised you, I said to you, we have a quality talk. It's not just about high blood pressure. It's not about the number. It's, preventing the cardiovascular. And you see all the emphasis being how to get there and, you tackle this, the implementation of it, tackle the adherence, getting simplification of the medication, getting the right medication on. So to prevent the vascular process, then what happened once that happened? Once we get atrial fibrillation, which is one of the results of uncontrolled blood pressure, this will be Dr. Hani's talk, take us through where to use the NOACs in atrial fibrillation in high-risk patient, and to talk to us about which NOACs, which patient, which phenotype, what to do with term of bleeding and balance. And Hani, we're looking forward to your talk.
Assalamu alaikum. Thank you very much, Dr. Abdullah. It's a great pleasure and privilege to be part of this important meeting. And we'll be talking a little bit about preventing stroke in patients with atrial fibrillation. It's always a pleasure to follow my dear friend and colleague, Dr. Samer, who, as usual, makes a very precise and very clinically efficient assessment of hypertension and the modern therapies available. So let's see. Can you see the slides?
Yes, go ahead.
Righty then. So as you know, we have now 4 different novel or direct oral anticoagulants, and they are in routine clinical practice. So I think it's very important to refresh our information about which NOAC to select in the higher risk population. This is my introduction slide. So I'm going to start with a couple of quick questions. Which of the following direct oral anticoagulant specifically reduces ischemic stroke? Is it dabigatran, apixaban, rivaroxaban, or edoxaban? Has a specific indication for reduction of ischemic stroke. So unfortunately, we don't have a QR code for the audience response, but this is the actual answer. Dabigatran specifically reduces the risk of ischemic stroke greater than any of the other direct oral anticoagulants, and it's a testament to its potency, and this is evidence-based medicine. Now, here's another important question. Which direct oral anticoagulant actually has a higher bleeding risk in diabetic patients? And I can bet you that most of you don't know this. So this is actually highlighted in the evidence-based medicine as well as the guidelines. And I think it's very important to be considered in a population where about 30 to 40% are diabetic or pre-diabetic. It is actually apixaban. So in the randomized clinical studies for apixaban, diabetics actually had a higher risk of bleeding than non-diabetics. This is not seen with dabigatran or rivaroxaban. So it's something to confirm and consider. Now, also, correct dosing. You have to use the correct dose for the correct patient. And unfortunately, worldwide, the underdosing of DOACs is incorrectly applied and it does not help the patients. So, what's the correct dose of a DOAC in a patient who is 74 years old, female, creatinine clearance more than 30? Is it apixaban 2.5 twice a day? Is it dabigatran 75 twice a day? Or is it dabigatran 110 twice a day? Actually, the answer is dabigatran 110 twice a day, not 75 and not Eliquis 2.5. This is evidence-based medicine. I think this is important to realize whenever you have a choice of dose and a choice of medication, you have to think about what is the requirement. So this is 110 twice daily, correct dose for this patient. Now, what's the correct dose of DOAC in a patient with AFib, recent PCI, 55 years old, normal creatinine clearance, and on antiplatelet therapy? Do you need to reduce the dose of the DOAC? So the answer is here. Unfortunately, I didn't give the correct animation, but is it the standard dose of dabigatran, 150, the standard or reduced dose of dabigatran, 110, reduced dose of Eliquis, or reduced dose of rivaroxaban? Actually, according to the guidelines, this patient with normal kidney function, low bleeding risk, on dual antiplatelet therapy, you initiate with the dabigatran 150, and then you reduce the aspirin after 4 weeks. So this is the important evidence-based medicine that we have to remember. Now, while most doctors, including many of us who are on this call, are going to be a little bit anxious and say, I'm going to lower the dose, the answer is not evidence-based and it's not scientific. So let's dig into some of this data. Are all the NOACs equal in high-risk populations? So one of the important populations that we need to talk about is atrial fibrillation and diabetes. Beyond glycemic control, what other things can you offer to the AFib patient who has diabetes from evidence from the landmark clinical trials and the large subgroups of diabetic patients that you can do a lot better in reducing their chances of having an ischemic stroke? So when you're looking at the perfect of anticoagulant, the one agent that has the highest reduction of ischemic stroke is in fact the dabigatran. When you look at the risk of ischemic stroke, it is the largest one, and it varies up to 74% in patients on the 150. Now, what are the ones that have the largest renal elimination? Are dabigatran, which is 80%, and edoxaban. So when you have high-risk patients and renal function, you have to do a multi-step assessment for reducing the dose for rivaroxaban and apixaban. What about once daily dosing? Well, that exists with edoxaban and rivaroxaban. However, if you look at any ideal anticoagulant with every feature that you want, complete safety, complete efficacy, utilization in all types of patients with all kidney functions, you will be disappointed. So I think this is an important paper that was published and presented almost 10 years ago. And it still stands true today that there is no ideal single agent for each patient. So you have to use a lot of clinical judgment in order to find the one that works best for your patient. So a patient with the highest risk of ischemic stroke, patients with recurrent ischemic stroke, dabigatran is evidence-based. Patients with significant kidney disease, you're probably going to use something else. And I would mean patients with a creatinine clearance less than 30. Patients in whom the creatinine clearance is over 95, in the FDA label, edoxaban is mentioned. And as we talked about renal dosing, for patients with modest reduction in renal function, there are specific protocols, including age and body weight, for reduction of rivaroxaban. So these are the clinical trials also in patients with AFib and PCI. And noting that the evidence was generated from these studies, which are mostly safety studies. In the Pioneer AFib, they used multiple different doses of rivaroxaban, 2.5 BID, then rivaroxaban 15 with clopidogrel or rivaroxaban 15 with aspirin. And they looked at the number of patients with significant bleeding at 12 months. The redual PCI with dabigatran 150 or 110 with clopidogrel or triple. And the Augusta study was apixaban 5 or 2.5 with warfarin and P2Y12, and aspirin was removed from the study. So let's look at the conclusions that come from first real-world evidence, and then we'll come back to all of the individual studies as well. So Dr. Coleman, who's really one of the experts in direct oral anticoagulants, publishes important meta-analysis comparing warfarin with non-warfarin anticoagulants. And because it's a systematic meta-analysis, this was independently conducted, not sponsored by any pharma company, and actually had a specific impact in reducing author bias. So just to summarize this important point here, you'll see it, that apixaban was not different than warfarin for either ischemic stroke or discontinuation rate, i.e. in terms of efficacy. In fact, there was lower risk of intracranial hemorrhage, which is a feature of all the DOACs. This is a class effect, but not different to warfarin in terms of ischemic stroke or adherence in the long term, which again is important to realize that the bleeding reduction is actually not different than warfarin in patients with apixaban. There was no difference in ischemic stroke, but fortunately, intracranial hemorrhage and hemorrhagic stroke was lower, which is a class effect of the entire group of DOACs. Rivaroxaban, stroke and systemic embolism and intracranial hemorrhage was better than well-controlled warfarin. Dabigatran, both stroke and systemic embolism and intracranial hemorrhage were better than well-controlled warfarin. And these are hundreds of thousands of patients that were enrolled in this real-world study. So let's come back a little bit to the diabetic subgroup. What proportion of patients enrolled in the NOAC RCTs are diabetic? Is it 20%, 30%, or 40%? So I would like to tell you that in the studies, the majority of patients who were diabetic were between 30 and 40% in all of the clinical studies. And therefore, they are very well represented. One, in terms of the risk of stroke, as part of the CHADS VAS score, the D is for diabetes, and two, in terms of real-world evidence, and even more here in the Middle East. So what are the elements of cardiovascular risk in type 2 diabetes? So diabetes is a lethal progressive disease which has cardiovascular and renal implications and is typically detected by an elevated glucose or A1C. Cardiovascular disease is atherosclerosis and MI and heart failure, and also atrial fibrillation. Since AFib stroke risk, CHADS VAS score is a major component of it is diabetes. So most of the patients with diabetes are actually at increased risk of stroke, whether it's atherosclerotic or embolic due to AFib. They constitute between 36 and 40% of the population in the 4 large trials. In addition, these patients are also at risk for other cardiovascular events, and therefore the total cardiovascular protection is very important. And in fact, in diabetes, and as well, Dr. Simon mentioned this, the use of ARB or angiotensin converting enzyme and blood pressure control is a key metric of vascular protection, in addition to what you're doing in terms of dyslipidemia and AFib stroke management and anticoagulation. Now, simply to come back to this diabetes issue, it is one of the most common concomitant diseases in AFib. I would challenge you to find a patient with AFib who isn't diabetic or pre-diabetic. Remember that they also have diabetes and AFib together increases cardiovascular events and all-cause mortality. And in patients in the UAE, about 40% are diabetic or pre-diabetic. So the hazard ratio of all-cause mortality, heart failure, or stroke is approximately 60 to 70% higher in patients with AFib and diabetes. Why is this? Because diabetes causes glycemic fluctuation, oxidative stress, and inflammation. It causes anatomical remodeling and imbalance of the sympathetic and parasympathetic activity. Electrical remodeling, specific currents in the atrium of patients with AFib and diabetes are more likely to be prolonged, and action potential duration makes it more likely to have AFib. Atrial remodeling, including atrial fibrosis, and structural remodeling due to growth factors and dilatation and diastolic dysfunction lead to increased AFib, and AFib itself leads to increased heart failure with preserved ejection fraction. Atrial fibrillation is also highly prothrombotic. So that's why if the patient remains in sinus rhythm or has paroxysmal AFib, you have to continue anticoagulation if they have diabetes as one of their risk factors, because you have the stasis, the platelet aggregation, the increased thrombosis, the atrial changes, and the atrial matrix changes that cause persistent endothelial dysfunction in the atrium. So even if they're in sinus rhythm, you cannot stop anticoagulation. Now, there's also another very interesting aspect of this, and it was discovered in the DECLARE outcome study using SGLT2 inhibitor in patients with diabetes who did not actually have known AFib. There was a significant reduction, both absolute and recurrent, in patients with atrial fibrillation of new onset of atrial fibrillation using SGLT2 inhibitor. This is not to say that SGLT2 inhibitor is an antiarrhythmic. It changes the substrate, the inflammation, and the structure of the myocardium, and also has some impact on blood pressure and tissue metabolism, which actually reduces the likelihood of new and recurrent atrial fibrillation events, regardless if they had previous AFib, heart failure, or ASCVD. So the diabetes subgroup is a very important one, both clinically and in the region. And we do have these large pre-specified subgroups in the DOAC studies, well represented. Within the studies, from 25 to 37% of the population, depending on the trial, these are pre-specified analysis, robust and valid, and statistically relevant. These are not post-hoc analysis where there may be a bias. These are pre-specified by the trial and the FDA. Now remember, in 2008, the FDA required cardiovascular outcome studies in diabetic patients with any cardiovascular drug and diabetes drug because of the unrecognized effect of rosiglitazone in heart failure and diabetes. It is well recognized, deserve further attention, and therefore every randomized study in DOACs or NOACs for AFib has included a pre-specified DM subgroup. So let's look historically at the ROCKET AFib study. The ROCKET AFib study had a large diabetes subgroup, 39%, 40% to be exact, of 5,600 patients. And they looked at the efficacy of rivaroxaban versus warfarin in AFib and diabetes. What did you see here? In patients with diabetes, whether it was warfarin in dark green or rivaroxaban in pink, this is dotted with diabetes, 5,600 patients, 39% were diabetic, and rivaroxaban is as effective as warfarin for stroke prevention in diabetes with or without atrial fibrillation. The event rates are lower in general in diabetes, but if you put rivaroxaban or warfarin on these patients, they still have a significant event reduction. Now, the offset of this was there a difference in major bleeding, major or non-major clinically relevant bleeding, with diabetes 14%, with warfarin 15%, without diabetes 15 and 14, no significant p-value. With major bleeding, again, with diabetes or without diabetes, the numbers are smaller, but there is no difference compared to warfarin and rivaroxaban. Therefore, you can clearly say that safety and efficacy of rivaroxaban in diabetics in the ROCKET AFib study with high CHA2DS2-VASc score was established. In fact, when you looked at the greatest reduction in stroke were the diabetics given rivaroxaban, minus 26% reduction of stroke and systemic embolism. This is for stroke in particular. And this was rivaroxaban without DM, rivaroxaban with DM, significantly different than the well-controlled warfarin. So this is a 26% reduction that you see. So the diabetic patients are actually getting a benefit. This means that it is very reasonable to use rivaroxaban alternative to warfarin in stroke prevention in patients with AFib with or without diabetes. You don't have to worry about it. Now, the RELY, which was the first study in DOACs and AFib, again, there's a very large diabetes subgroup analysis, and this is a long term. This is almost 15 years, 16 years ago, and I think it's very important to go back and think about this. Again, diabetes is a major independent risk factor in stroke in patients with and without AFib. It's included in the CHA2DS and the CHA2DS2-VASc score. In the RELY study, 23%, 4,000 patients, had diabetes at baseline. And they did look at the sub-analysis. So, just to make this a little bit more interesting and to remind you of something I mentioned right at the beginning, are the efficacy and safety of all NOACs in the diabetic subgroup same in all the RCTs? The answer is no. Actually, not. If you take the diabetes subgroup analysis by treatment group, whether they were getting 150 of dabigatran or 110 of dabigatran, stroke and systemic embolism, vascular death, all were significantly lower compared to well-controlled warfarin, whether you use the 150 and 110. What also is very important, that major bleeding with both doses and intracranial bleeding with both doses were significantly reduced as well. So this is telling you that the presence of diabetes is not affecting the efficacy whether you use the lower dose or the higher dose. So in basic events, when you are looking at stroke and systemic embolism in patients with or without diabetes, in patients with the higher or the lower dose of dabigatran, there is an efficacy benefit using dabigatran compared to warfarin, either dose with or without diabetes. And when you look at the diabetic patients, the risk of major bleeding with the lower dose and the standard dose were less than well-controlled bleeding. This is a very important concept to remember. So dabigatran provides a consistent efficacy and safety benefit versus warfarin in patients with and without diabetes. So is this effect in diabetic patients consistent in all DOACs? Actually, the answer is no, which is the one we're going to discuss now. In fact, in the Aristotle study with apixaban, in the original publication, diabetics had a different outcome. And in fact, the Aristotle Steering Committee published another paper from the committee and the co-PIs to describe the unusual and different outcome if you use apixaban in diabetic patients with AFib. So initially, again, I mentioned this is a pre-specified outcome and required a separate paper because it was one unusual thing and it was different than the other trials. If you look here, the bleeding risk in Aristotle was different significantly over here, 0.03. If you were diabetic, you had more bleeding. If you were not diabetic, you had less bleeding, which means that warfarin is the same as apixaban in causing bleeding in diabetic patients. This was quite unexpected, quite unusual, and different from any other subgroup, and therefore required a separate paper. So, when you look at intracranial hemorrhage, I'm not talking about intracranial hemorrhage. Intracranial hemorrhage is now solidly a class effect. It is significantly lower in patients compared to warfarin. So here's warfarin here, a much higher intracranial hemorrhage rate, whether they were diabetic or non-diabetic. Apixaban, again, intracranial hemorrhage, diabetic and non-diabetic, there is a protection. So all DOACs reduce intracranial hemorrhage. However, unlike the ROCKET study with rivaroxaban, RELY study with dabigatran, diabetics have no safety benefit with apixaban from major bleeding. In the Aristotle study, only the non-diabetic patients over here who are getting the other agent, which is apixaban, have reduced bleeding. On top here, you see three overlapping curves. Diabetics receiving apixaban, diabetics receiving warfarin, and non-diabetics receiving warfarin. So apixaban only reduces major bleeding in non-diabetic patients. Everybody else is exactly the same as warfarin. So therefore, the conclusion is diabetic patients were actually not systematically protected from bleeding compared to non-diabetics. The interaction between diabetes and the ISTH major bleeding was significantly different even after adjustment. The p-value is 0.0052. This is not due to chance. This is definitely related to the medication. So just to highlight this point again, ISTH major bleeding showed no safety benefit with apixaban. So diabetics actually are all buckled up here. Increased major bleeding in diabetics on apixaban, identical to warfarin. So this common idea or narrative that in patients who have diabetes, it's okay to use apixaban to reduce the risk of bleeding, this is not correct. Now, in general, ISTH major bleeding was less common in the overall population, but in diabetic patients, this reduction was non-significant. Apixaban diabetics, 3 bleeds per 100 patient years. Warfarin, 3.13 per 100. Is exactly the same as warfarin. Now, expressed in a different way, if you have 3% of diabetics versus 1.8% of non-diabetics, there's a significantly higher risk of bleeding. And if you take clinically relevant non-major bleeding or major bleeding together, 5% of diabetics had some bleeding, 3.7% of non-diabetics had some bleeding, and it is statistically significant. So there is an important difference in diabetics that you should not ignore when you are having a choice of multiple anti-thrombotic agents. There is 1.7 times more major bleeding in diabetic patients receiving apixaban than non-diabetic patients, and this is significantly important, and it's the same as warfarin. The numbers are identical to warfarin in the diabetes subgroup. Okay. Now, what type of bleeding? This is important. Not all bleedings are the same. GI bleeding was 50% higher in the diabetic patients here receiving apixaban. This is diabetes versus non-diabetes. GI bleeding lower was again 50% higher in patients with diabetes versus non-diabetes receiving apixaban. Intraocular bleeding and rectal bleeding again were higher in patients receiving apixaban who were diabetic compared to non. Remember, this was a randomized, blinded control study. There is no bias in this paper. So a significant increase in GI bleeding, a significant increase in lower GI bleeding, rectal bleeding, intraocular bleeding, and other major bleeding sites in patients who were diabetic who received apixaban. Now, in total, out of the 18,000 patients in the apixaban study, Aristotle study, 4,000 out of 18,000, 24% were diabetes. This was a pre-specified analysis published by their authors. There was no significant reduction if they had diabetes in stroke or systemic embolism. It crossed the line of identity. All-cause mortality, again, not statistically significant, numerically so. Cardiovascular mortality, and in fact, myocardial infarction was slightly higher. Although, again, the numbers are small. Patients with diabetes receiving apixaban had similar rates of major and non-major bleeding as warfarin. Now, the conclusion of the paper that was written by the steering committee of the Aristotle study came back to this last paragraph. The observation that apixaban results in higher rates of bleeding in those with diabetes is unexpected and deserves further investigation. So, one of the things you have to consider now is the right medication for the right patient, and diabetes is a big one, and also the right dose for the right patient. And I think this is very important because underdosing is happening all over the world, including in the region, and it's not helping your patient. So, the common utilization in real-world practice, and you know this, in Aristotle, 2.5 milligrams of apixaban twice a day was only appropriate in 5% of patients with AFib, right? In clinical practice, 63% of patients receiving apixaban are underdosed, receiving this unapproved dose of 2.5 milligrams. This increases the thromboembolic risk and underestimation of bleeding versus the standard dose. There are also two fully tested doses of dabigatran, 110 and 150, providing the flexibility to do evidence-based patient characterization. And as I showed before, dabigatran has a favorable safety profile in multiple clinical settings and also has an ideal specific reversal agent. So, very important if you're underdosing apixaban, and unfortunately this is a common scenario. We've seen it here in the UAE. My friend Dr. Mu'taz Al-Qadri did a paper where they looked at the medications that are frequently underdosed, and apixaban is number one. 63% of patients receiving apixaban are getting the wrong dose. You're not helping the patient this way. Now, the prescriptions of low-dose apixaban are disproportionately high in many countries. So US, Japan, Canada. In the clinical trial, only 5% of patients were getting 2.5 BID. However, in the world, the dark yellow or orange, 77 to 62% of patients are getting the low dose inappropriate. When do you reduce the dose? When the patient has age more than 80 and body weight less than 60 and a serum creatinine of more than 133, 1.5. So that's the problem. You have to have two adjustments, not one. Unfortunately, most doctors have this mindset of, well, I'm going to reduce the dose because of one. And number two, if the patient has diabetic, even the standard dose is not protecting them against bleeding. So this is the key point of the evidence-based medicine. 5% less than 2.5. In the large Orbit AFib registry, 37% of the patients were getting the appropriate dose, 63% were not. So, Real-world data also suggests there is an increased risk of mortality using low-dose apixaban versus warfarin and a higher stroke risk versus the standard dose. So if you can see this slide, I'm sorry, it's a little bit busy. If you take lower dose of apixaban, this is in here, there's a 48% in the Danish population using the 2.5 BID inappropriately compared to 110 BID of dabigatran. There's a statistically significant higher likelihood of death. And when you look at all-cause mortality with the dabigatran, correctly adjusted, mortality is at the zero line. But if you use a underdosing of apixaban here up to 10 milligrams, mortality will increase as well. Thromboembolic events in the ORBITS registry using the apixaban, again, underdosing of apixaban or rivaroxaban increased thromboembolic events by 1.5% and death by 2.6 times. So using the lower dose does not help the patient at all. So what do you get from the evidence-based medicine of the use of dabigatran in the lower dose? In the RELY study, these patients were divided 50-50, 110 and 150. In the European label, which was adjusted to include the renal function, including the multiple real-world settings of cardioversion, post-PCI, 150 milligrams with creatinine 30-50, and 110 if a patient is at increased bleeding risk or getting concomitant verapamil. And this was tested in the randomized clinical studies. It's not an assumption. There's a huge number of patients like this. The 110 milligram BID was fully tested in 6,000 randomized patients. There is a lower risk of major bleeding, lower risk of life-threatening bleeding, a 70% reduction of intracranial bleeding, and a non-significant increase in major GI bleeding as well. The 110 milligrams, again, if you use the European label, again, you get the benefit and the safety together. So overall, if you look at the Gloria AFib study, and Dr. Abdullah was actually the principal investigator for Gloria AFib in dabigatran when we were working on that in 2014. UAE was a major center comparing of the study. There was significant, very low risk of life-threatening bleeding, vascular death, major bleeding, and stroke in real-world evidence. And this study, 55% of patients received 150, 43% received 110, and only 2% received 75. So over 2 years of follow-up in real-world evidence in the UAE, very low risk of stroke, very low risk of major bleeding as well. So I will just very briefly compare the RELY and the Aristotle study. As you know, RELY looked at 3 different components: warfarin with an INR of 2 to 3, dabigatran 110, 150. Aristotle had 5 BID was the standard, and literally less than 3% of those patients were on apixaban 2.5. So this 2.5 reduced dose is not systematically or robustly studied, and you should not be using it unless there's a very convincing 2 reasons to do that. So when you look at the recommended dose and you look at the current EU label analysis, the difference between well-controlled dabigatran and well-controlled warfarin, still less major bleeding, stroke and systemic embolism, still less stroke and systemic embolism compared to well-controlled warfarin. So that's the p-value. And the Aristotle study, which I mentioned, where you had a use of the correct dose, 5 milligrams BID, not the reduced dose, you still get the benefit compared to well-controlled warfarin and a slightly lower benefit in terms of stroke and systemic embolism, but it is statistically significant. The utilization of GI bleeding, does dose reduction reduce that? Actually, when you compare the 150 versus warfarin versus 110, similar risk of major GI bleeding compared to warfarin. And in rivaroxaban 15, if the creatinine clearance was reduced, yes, you get a reduction of the GI bleeding. And this is an important difference. Don't reduce the dose if you don't need it. So what clinical studies have shown us the various different doses? Dabigatran has been tested, 110, 150, in stroke prevention, in cardioversion, in ablation, and redual study. The Pioneer study used actually different doses, 15 once a day, 10 once a day, and 2.5 BID. In the major studies for AFib, cardioversion, and ablation, the standard doses are used. So, just to come back to the summary at this point, dabigatran, used according to the European label, is associated with a significantly lower rate of major bleeding events versus warfarin. Rivaroxaban is similar versus warfarin, and you should use again the standard dose when needed. Consistent doses of dabigatran, but not rivaroxaban, have been tested in multiple cardiovascular settings with standard doses that you're familiar with as well. So there are, excuse me, large real-world analysis comparing dabigatran, which remember was first approved in 2010 with apixaban, and this was propensity score matched over 300,000 patients looking at the risk of major bleeding of dabigatran versus apixaban. So they're actually, in the real world, 50% increased risk of major bleeding for apixaban, regardless of the dose used. So I think this narrative that one medication is safer than others is actually not correct, and you should be very careful when you're listening to this kind of data. So the reduced dose of the inhibitors is greater in real-world practice than in clinical trials. So if you look at the reduced dose in dabigatran 50-50, rivaroxaban is only 21%, apixaban 5%, edoxaban 25%. In real world, doctors often default to using the lower dose, and I'm not entirely sure why that keeps happening when the evidence does not support it. And this is, again, something we've shown earlier. So I just want to come to the last couple of slides regarding the use of well-controlled warfarin in post-PCI patients versus dabigatran. So if you looked at patients who received, this is the REDUAL study after PCI, so these patients were getting triple therapy or dual therapy. And if you look in the warfarin arm, the bleeding events were significantly higher than either dabigatran 150 in dark blue or 110 in light blue. Major bleeding, again, higher with warfarin, intracranial hemorrhage, higher with warfarin, and much, much lower. So it's quite clear that the use of the DOAC has reduced the risk of bleeding in any post-PCI patient. And what we've learned from the guidelines and the evidence is that you can stop aspirin, and I think this is very clear, aspirin discontinuation continues to be lower bleeding. So this is without aspirin, this is the 150, this is the 110, and any event at all does not increase the risk of bleeding and does not increase the risk of thrombosis. If you look at the Augusta study, which looked at apixaban versus warfarin without aspirin, again, the aspirin is what increases the risk of bleeding compared to placebo, and the warfarin increases the risk compared to apixaban. So do you actually need aspirin in the immediate post-PCI period? Make it as short as possible. And there again, the benefit of using a DOAC, which in this case was apixaban, compared to warfarin, is significant in terms of intracranial hemorrhage versus others. However, apixaban itself, again, is not without major bleeding. So I want you to really be focused on this information. So after 2018, which was after the Augustus and the REDUAL study and the Pioneer study, the whole point is this, that you can shorten the duration of triple therapy quite safely in patients with high bleeding risk. You can just go to the oral anticoagulant and the P2Y12 alone. If the patient is lower bleeding risk, you can make the triple therapy only for 1 month and then go to single therapy with OAC after 12 months. So deleting the aspirin increases the likelihood of safety and decreases the risk of stroke. Finally, a couple of words on reversal agents. So we've had this reversal agent now for over, since 2017, so almost 9 years. This is a reversal agent that is specific to dabigatran. You can't use it for apixaban, you can't use it for edoxaban, and you cannot use it for rivaroxaban. It is very simple to inject. It's a 5-gram dose. You inject immediately, and it stops the effect of dabigatran by binding it specifically. So it's very easy to use. And then once the bleeding stops, you can reinitiate the dabigatran because it doesn't stay in the system. Adexanet alpha is supposed to be a universal agent that acts on factor 10A inhibitors, all three of them, plus low molecular weight heparin and unfractionated heparin. And this, unfortunately, has been having a lot of issues with the FDA and a lot of warnings and black box warnings due to recurrent thrombosis, and is currently in a holding pattern. So, just to summarize what we have over now 16 years of the Bigatran experience. So this was the first DOAC launched in 2010. So long-term studies after RELY and Gloria AFib. In patients with ablation, risk of major bleeding compared to warfarin in the redual study, risk of major bleeding reduced using dabigatran dual therapy versus warfarin triple therapy. And then surgery and urgent reversal, we have a very clear reversal agent that's easy to use. The other reversal agent is not specific and is also having some problems in terms of its recurrent thrombosis. And now the lower dose of dabigatran, again, is fully tested in elderly and vulnerable patients. So just to remind you of two important points as we close today, reduced dose dabigatran was inappropriate in 63% of patients in real-world studies and increases the risk of both thrombosis without decreasing the risk of bleeding. Reduced dose of apixaban has higher mortality than warfarin and higher overall thromboembolic events. The two evidence-based doses of dabigatran, 150 and 110, are fully tested in multiple cardiology settings. There are some clinical gaps for apixaban, particularly in diabetic patients, and tailoring the dose of dabigatran to the patient's thromboembolic risk, the presence of diabetes, compared to apixaban with multiple different criteria. And particularly the noting on diabetes is extremely important given our high-risk population in UAE. Thank you very much, Dr. Abdullah. I'll return it back to you for discussions and questions.
Outstanding, Hani, as usual, from Boston speaking to us. I don't know what time is there, but maybe in morning. So I hope you guys all enjoyed the session. We have around 100 attendees. So we discussed tonight not two different, diseases. I can say in like a one patient journey, having a high blood pressure, not being attended, maybe say, okay, it's fine, the blood pressure, as Dr. Samer said. We forget to get the patient, not only the target is to get them consistently right, and variability we forget about, adherence we forget about. Then what happened? These patients silently have atrial fibrillation. Then if that's not been treated effectively with the right medication, personalized medicine, as they call it, then we have a stroke, then we have a bleeding. We have patients who have issues with fear of bleeding and underdosing and so on and so forth. So it's many things happen with these two talks. Let's open the discussion, and I can see there is no question. Let me start with a question for Dr. Summers, since you are into quality as well. If target is not an issue, and we, as a physician, we only see patient in the clinic, only 5 minutes. So that's our target. I mean, we cannot see them afterwards. And then what happens, we are happy with what we get, if we do it properly. If we do the blood pressure, we get the blood pressures right. Okay, I'm happy. Then you nicely say there is something called, blood pressure variability, which we forget about. The spike blood pressure, when they get, I don't know, that's where the events happen. If that's important, Dr. Samer, if that's the blood pressure variability is important, first of all, why not in the guidelines? Second thing, how should we treat that? I don't know. I mean, how should best, you talk about digital, but again, digital is cause confusion more than help sometimes. I'd like you to discuss that in a fair way, because so people understand what's going on. Thank you.
Sure. Thank you very much. And Hani, as usual, thank you. It's a pleasure to be with both of you. So, as I said, heart rate variability is something we look at as cardiologists in general as favorable. Blood pressure variability, except for the diurnal, which is the drop of 10 to 20%, is usually not favorable. There are tons of data on this. I think I put 5 or 7 articles to support it. So as an intro, and as I said, and to reinforce the message of Dr. Ishab, major complication, not in the guidelines strictly. Still, the guideline talk about the actual number, more than anything else. And as I showed you, the flow. So it looks very simple. Like, what are the things that we can do? 5 things come to mind. Number one, the famous cuffless blood pressure, as you said, Dr. Shab, not yet reliable enough, may help with the engagement, but also may make the cardiologist and the physician crazy because of the repeated comments. There are only 4 cleared. Cleared means not approved, just cleared by the FDA, and still they need to be standardized. So while they are promising, that's not the solution for now. The guidelines call it class 3, so not indicated. Second option is the 24-hour blood pressure. We do it once. It gives us an idea. We know about dipping, non-dipping, reverse dipping, etc., as you know. But that's done once, not the solution. Good for some labile hypertension, good for some that have significant variation, but not there. 3, and that's the most important, is taking blood pressure at home. So this, as boring, as simple, the NICE guideline recommended, European recommended, etc., and telling the patient that this is more of a lifetime thing. This is not, they can do it daily, they can do it twice a day, they can do it once a week. 4, and very importantly, we need to incorporate this. So in my notes, I take a photo of the numbers that the patient give me, and I try to summarize what I saw so we can discuss it. And 5, and very importantly, as Dr. Shab mentioned, the goal is to get to blood pressure, say less than 130 systolic, using specific drugs that are long acting, but variation is still a major concern, especially visit to visit. I'm sure, Abdullah, you've seen cases where they are controlled today and then they come back to you all over, they call you, etc. In my humble experience and looking at the guidelines, looking at NICE recommendations, home blood pressure monitoring is the only solution we have.
And Hani, let me get back to you, because as very nicely, beautifully said, practical guys, just take note of that. I think very important. Hani, if we are all done fine, what Dr. Samer said, are we able to prevent atrial fibrillation by controlling blood pressure, and how?
So there are some factors that can be used to lower the risk of atrial fibrillation. So blood pressure control is very important. Weight management is very important. Sleep apnea management is very important. So in fact, when we are offering a patient an AFib ablation, what most electrophysiologists, including myself, insist on is a sleep study evaluation beforehand, because the recurrence rate is much higher if you don't treat the sleep apnea, and some weight management. In fact, if you reduce the body weight by about 5% only, not only is the sleep apnea improved, but you're also reducing the risk of recurrent atrial fibrillation. So this is a must in people who have AFib. So preventing recurrence of AFib, it's fairly obvious that blood pressure control, risk factor control, weight management, and sleep apnea is really important, and it is part of the standard evaluation of any young person with AFib. And I mean these patients who have no structural heart disease, obviously patients who don't have heart failure.
So, Dr. Samer, now patient got atrial fibrillation and hypertension in your clinic. And the blood pressure, as you said, using this 10, whatever is it's very nice.
Rule of 10.
I like that one. Yes. Okay. So and the guidelines say you start combination. So having atrial fibrillation using CCB, is that okay with you for hypertension AF? I mean, what's going to be management of hypertension AF?
That's a great question, as usual. So we'll go by the guideline. I find the simplest are the American and the European, not the international guidelines. So the guideline clearly stated, depending on where you are in the response, we're going to flow from stage 1, 2, or 3. And this is a compelling indication for a beta blocker, at least in my book. So now what you're going to do is do all what you typically do, which was what we did. We said, if the blood pressure is slightly elevated, we'll use one drug. If it's more elevated, and I can give examples, then we'll use combination low drug 2. And then if not, combination 3. But if you remember that arrow, we will add beta blocker as needed. A beta blocker will have 3 benefits. Number 1 is obviously heart rate control. Number 2, and very importantly, the cardiovascular protection. But number 3, and very importantly too, is it decreases, not abolishes variation. So this would be a case where beta blocker are clearly indicated. You could argue that you could use other forms of calcium blocking agents such as diltiazem, etc. But per the guidelines, as a typical case that you discussed, this is a recommendation. And I think for you and me and Hani, it works many, many times, if not most of the time. The problem is, like there is inertia with AFib, like there is inertia in hyperlipidemia with hypertension, there is always a delay in treating these patients. We're talking about, if we talk about hyperlipidemia, 4 to 6 weeks. For blood pressure, again, you could argue that it's 2 to 6 weeks. So this needs to be progressing very consistently.
So normally, if you started patient on a combination and then you see patient what in a 4 weeks, 6 weeks,
The recommendation,
based
the
on your
guidelines
clinic,
are, yeah,
your
between,
clinic, in your clinic. Now forget about the guideline. Guidelines
for
is
me, 2 to 3
yeah,
weeks routinely,
very
depending on
good.
the
So
drug, etc. Because if
yeah,
you don't do it quickly and you don't
yeah,
address it, we
yeah,
are inertia. Inertia is not treat or not treat. Inertia is
right.
moving, and this will need overbooking. So Dr. Hani and I are known to be overbooking patients, right, Hani?
Yeah,
So
100%.
our clinic is like an accordion. It keeps on adding because if you say till there is an appointment, I'm sure you Abdullah too. If you say till there is an appointment, patients are gonna die. We have to overbook and accommodate these patients. Another thing is second visit always has three rules. Rule number one, bring your blood pressure device. Sometimes they do, sometimes not. Number two, bring all your medications, including over-the-counter, stimulants, whatever they do. And then number three, and very importantly, is give us the home blood pressure for 2 to 3 weeks, which most of them do.
So beautiful. You just heard, attendees starting combination. Get the patient as early as possible because you want to make sure the follow-up that's what we're missing with our patients. That's where we are not getting to control. It's not getting that control in your clinic, it's to get control on follow-up and that consistent. Beautiful. Honey, Rao, these patients having atrial fibrillation, diabetes, this is very common, obesity in our region, and hypertension.
Yes.
Then coming to the NOACs. We're looking at the NOACs in the country. The highest use of NOACs is still apixaban, and why the reason for that? And then second, you think the dabigatran has got two ends. One is using for ischemia, mortality benefit. The other one is they have I don't know what you mentioned, but something else regarding diabetes. Can you maybe
Yes.
re-emphasize that again?
Sure. So, as you have worked with us very closely on the cardiometabolic guidelines, and we are sort of very familiar, Dr. Salman, I'm sure also on the audience, is that a lot of our patients are diabetic and pre-diabetic. Okay. Now, if this patient develops AFib, their risk of cardiovascular events is higher than a diabetic patient who doesn't have AFib, and the risk of stroke is multiple times higher, right? So now I am faced in my clinic with the reality of data that has been published and validated since 2015 and is specifically stated in guidelines that in diabetic patients, apixaban does not make the risk of bleeding less. In fact, it is more and it is similar to warfarin. Now I have three options in terms of treatment. A patient with high ischemic risk, also multiple risk factors, high CHA2DS2-VASc score, right, who is diabetic, my choice is not to use apixaban. There's no reason to do that. It does not lower the risk of bleeding. And there is this weird perception amongst colleagues that apixaban has the lowest risk of bleeding against all DOACs. This is not true in diabetic patients. It is statistically and clinically not true. So, high bleeding risk, you're not going to benefit the patient by reducing the dose. High bleeding risk, you're not going to benefit the patient by using apixaban if they are diabetic, and that's part of their bleeding risk assessment. Now, if the patient's not diabetic, all options are open. Everything is better than warfarin, right? Less bleeding, less stroke, you're good. Patients with recurrent ischemic events, multiple TIAs, multiple strokes, dabigatran is the most powerful, okay? Patients with higher risk of intracranial bleeding, dabigatran lowers intracranial bleeding than others because it's a factor 10A only. It doesn't affect the others. So, it's really very important to try to remember the data. But you are right. The low dose of apixaban, 2.5, is incorrectly used in patients who don't need dose adjustment. And there's a lot of apixaban use in diabetics in patients who don't benefit from it. So I think we have to have rational choices based on the patient in front of us. And if it doesn't fit the guidelines, it doesn't fit the data, don't use it, right? So I think that's the point. People think that it has a lower bleeding risk. It's not true in diabetics. And lowering the dose does not lower the bleeding risk at all. If you use the wrong dose in the wrong patient, you are not helping, you're only giving a placebo.
So let's be more specific here. And I mentioned data says that the use of this apixaban is highest worldwide, and
Yes.
here. And the reason you think is because it's easy to use underdose. I mean, why are they still using it if they think that data, which you mentioned, is convincing? I mean, you say it's convincing to you, but is it convincing to them? Why they are using apixaban, not using the dabigatran?
Right. So when you look at the overall data that is presented for apixaban versus warfarin in the Aristotle study, yes, the risk of bleeding in general was reduced. That is correct. But that does not differentiate the diabetes subgroup. And even the original
So for
authors,
diabetes, we should be
yes,
careful. That's what you meant. And because
very
that's
clear,
very high in our region.
very different, very clear.
Okay, so
Secondly,
guys, remember, when you come to diabetes, you need to be more specific and choose the right one. Dr. Samer, I know you are into AI and to digital and mashallah, publication, yani, countless. Now, how the AI help us with the complex patient we get nowadays? We get, patient with hypertension, all these comorbidities, already had on the wax and that. To say, look, this is combination of blood pressure is good medication for you as this NOAC instead of Hani, because Hani maybe not with me that day. I need AI to help me. How can AI help me in that one?
So I sent you the recent paper that Dr. Magdi Yaqub asked us to publish in his journal. And I'll just summarize what we tried to see in the paper. So we called it reimagining cardiovascular care using AI, blockchain, metaverse, and we call it NFTs. So very briefly, not to bore you with this, and for my colleague, I can summarize it into A, B, and C. A, the wearable concept. Unfortunately, for blood pressure, the wearable is not where it should be. Let's be very honest. I want to repeat, Dr. Shab, four are currently cleared. There is nothing called FDA approved device. It's called clear, but cleared with condition. The second one, name doesn't need to be mentioned. It says it needs to be repeatedly calibrated with a cuffed blood pressure. So this is out when it comes to the topic. For heart rate, for other things, absolutely. Second option is decision support system. So what do I mean by this? Incorporating into our electronic medical record a very intelligent system that allows us to look at all the data that we incorporate, that we put in the system, check all the guidelines that ever existed with a huge database. Let's say that the patient is from a certain country, I don't want to mention the name, but certain country, certain gender, certain age. The database using blockchain is incorporated, and then it gives you recommendation per the guideline. Who's going to remember the prevent score, how to measure and how to calculate it? So, Dr. Shab, I was in 1994. Some of my colleagues were not born maybe at that time. Anyway, in Washington, D.C., at the Marriott Hotel, and I was invited by the group that was focusing on hyperlipidemia. We were 1,200, okay? And they asked, how many of you are using Framingham risk score? Hani, how many think were raised their hand? Six. Hani, out of 1,200, Dr. Shab,
yeah,
six. So this will facilitate everything. The
automation.
CHA2DS2-VASc score and done properly. Other risk score, the bleeding score, which Dr. Hani very nicely knows and uses on a daily basis, and it will incorporate and makes a recommendation. So this is what we call intelligent advanced use of AI. There is now the third one, which is my absolute favorite, which is the prediction. So we're trying to work with our colleague in Abu Dhabi University, but the campus in Abu Dhabi, and Zayed University, and our colleague at Khalifa University, where we're trying to predict outcome based on the current information. And that is what's the most interesting. So, Abdullah, what we're trying to say very briefly is what you're talking about. as close as we can to precision medicine is not necessarily that you know the genes of the patient. That would be ideal, but precision medicine means based on a huge database, large data, we can predict who is likely to have a controlled blood pressure, on what regimen, prevent AFib, treat AFib, whatever AFib, okay? Ablate AFib when you need to. And that is what we're working on as we speak. And we have a paper that came up on this, but there's another paper. And it's work in progress. The challenges are three: data privacy, the ability to reach data and be able to do it, and also to have the physicians interested in doing this and proceeding with this. But the hope is great, but it's a matter of time.
Dr. Abdullah, if you can permit me to add something related to this. So just as an experiment, I wanted to test Google AI if it could answer one of the questions that we asked right at the beginning. Seriously, I'm going to show you this. It got confused. If you can allow me to share this for 1 second. Unbelievable. So, can you see it?
You just did it now?
Yeah, just now, as you were talking, literally, because we answered this question ourselves, right? So here's the share screen. Look at this. Continue to share. So this is the question we asked. The correct dose of DOAC in AFib patient with recent PCI, 55 years old, normal creatinine clearance on antiplatelet. Four possibilities, right? So we said that the dose of 150, low bleeding risk, reduced aspirin. Now, what did the Google AI, while you were talking, okay? It was searching, spent a couple of minutes thinking a little longer, and then, oops, something went wrong. It got the reference, but it couldn't answer the question because there's a lot of subtlety and nuance. So I don't blame the doctors for not having the instant answer in their head, but because this is a very detailed piece of medicine, it's really our responsibility to have a deep knowledge of the science. And this is, I think, why these very important studies are there. And I agree with you. The AI is going to change the way we do medicine, but sometimes it cannot answer every single question. That's why we are consultants. That's why we study hard. That's why we read the references. That's why we attend these lectures.
Inshallah, we have more of this by Dr. Sam in our upcoming meeting, inshallah. I asked
100%.
him and he immediately, mashallah, as usual, say, I am with you. Jazakallah khair. So
Yes,
my question
Abdullah,
now,
can I just say
yeah,
something to
yeah,
him?
please.
So I do this and I challenge because there is a hysteria, we call it, for the AI. And then you say why, or you say if you want to try it, and you say you are incorrect, I want to challenge you. And
Okay,
then through machine learning, this will go back. But we're not going to take too much time on this.
I
But
agree.
and
I do that.
obviously, first layer sometimes doesn't work. You have to go back, etc.
Exactly.
Exactly. Let's learn from you, honey.
It learns from you.
Yeah,
Yes.
yeah, right. So let's go back to our topic. So as nicely said, we are not treating number. We're treating the phenotype. We're treating the vascular. We're trying to protect that. So, but we still, if you look at the KPI, our KPIs are still numbers, guys. So how can we correct that one then? You are the quality man here, Samer and Hani.
So, number one, we're starting in our institution projects led by our fellows, which is going to look at hypertension, hyperlipidemia, heart failure, our favorite topic, and ACS. So standardizing care is key. And this is no question about it. Second thing, an easy number for us to remember, systolic blood pressure is less than 130, not less than 140. That's an easy one. It applies to almost everyone except above age 80 or 85, patient with orthostatic hypotension, as I mentioned, some patient with severe kidney disease, special cases, and very importantly, the frail patients. So that's regarding the number. What's the sequence? Allow me, Abdullah, to just give a 5 message in a row. Number one, and most importantly, before we treat anyone, we assess the risk of the patient. Number two, we ask about the diet and lifestyle history and see if there is a very, very unusual thing. I had a lady who came to me with this lipidemia. I gave her PCSK9 inhibitor just to put a smile on your face. And there was zero benefit. So she came back. I said, tell me about your diet. She said nothing. Her son said, no, mom drinks, you have to listen to this, 4 to 5 liter, I don't know how she can do it, of double cream milk every day
MashaAllah.
and eats 8 to 10 eggs. Okay? So please get a
طيبات
not
هذه.
طيبات.
Okay.
Seriously,
Oh,
you may think I'm exaggerating. I cannot obviously disclose, but get a history. So first, the risk of the patient. Second, the history. Third, define what the goal is and say the why. Why are we doing this? Not just lowering blood pressure. And typically it's less than 130 systolic over 80. Four, and very importantly, how we lower it, longer acting, combination, lower dose as we progress with compelling evidence like the excellent example of Dr. Shab with beta blocker. And then five, which is extremely important, is individualize, individualize, individualize if there is something particular. Some patient may not tolerate, they may get cough with an ACE, they may get with an ARB occasionally minor side effects. Explain to the patient that peripheral edema is not very significant, etc., etc. And this is what we do as physicians. We judge, we communicate, we educate.
One thing, Hani, and both of you, as a physician, we need to, of course, because we are physician, we reassess, reevaluate. I mean, we say this.
yep.
One thing I don't see it is static. Whatever we start with, I mean, Dr. Samer maybe, start a patient, then the patient get lost somewhere else. That patient remain in that medication,
Forever.
until maybe Dr. Samer see him in 2 years.
Yeah.
This re-evaluation not happening. What's the reason for that? I mean, we need to, patient ages, patient renal function changes. I mean, lots of things happen to the patient. Maybe improve his lifestyle. We need to modify medication. That's not happening in our clinic. How can we improve that one?
It's
Hani.
really having a standardized follow-up. I mean, in heart failure clinics, patients are followed routinely. They don't wait for the patients to have a amputation or go blind, right? In diabetes clinics, exactly the same thing. So applying the same structure and follow-up to chronic disease management, particularly in diseases that have high cardiovascular risk or have lots of options for implementation, is the most important thing. And as both of you mentioned, the use of home blood pressure monitoring, coupled with an application, right? Coupled with a warning system, right? Yes, the blood pressure monitors are not perfect, but the tool it's in the patient's hand. So if you think about it, a patient at home who has a home glucose monitor where the numbers are always high, well, they're going to go to the diabetologist and say, Doctor, this isn't right, right? Same thing. We use the blood pressure monitor to empower a systematic approach, link it to an appointment, make the patients understand, like Dr. Samer said, and you said, you have to see you back in 3 to 4 weeks. I need to see what's happening with your blood pressure. When people understand the urgency, and you showed such beautiful slides of the 10 millimeters of mercury, the 5 millimeters of mercury, the impact on stroke and heart attack, and making this number part of the patient's own discussion. And then having a home blood pressure monitor and having a system that they can call a nurse or come in quickly to the hospital or come in for a visit, it's really important. And the second thing is standardization. Really, we cannot be talking different languages to the patient. You tell the patient you need to reduce to 130. They go to some other colleague. They tell them, no, no, it's fine. Khalik, 140 is okay. You were fighting with your wife today. You had a rough day at work. You didn't sleep properly. You can't let the patients off a hook. This is a very important biomarker that is lethal and measures at home and have so many tools. So I think we just have to enforce the fact that this is hypertension is the most preventable determinant of cardiovascular disease that we can do and also has an impact on the kidney and stroke, right? So as our diabetes colleagues focus a lot on the HbA1c control and have systems in place, we all have to have systems in place for managing hypertension continuously, effectively, all the time. Every millimeter of mercury matters. I bet you most patients don't know this fact.
I agree fully. I cannot agree more with every word that Dr. Hani said. I will add just three simple comments. Number one, we are in this business of healthcare, and we need to go now to the ethics. I personally find it extremely unethical not to provide access to the same physician within 2 to 3 weeks.
Yes.
Even if the calendar, even if the schedule would inflate balloon, and I happen to have worked closely with Dr. Hani for almost 12, 13 years, and he remembers the clinic can be a balloon. It's okay. It's okay. We all have enough money. We all have enough pleasure and the days off, etc. The patient, when they feel that they are being seen, Dr. Shab, which I'm sure you do yourself even more than both of us, when they feel the commitment, the why, the initial education, and then they come in 2 to 3 weeks, fine. What is happening, hypertensive patient cannot be seen after 3 to 4 months. This is out in my humble book. They have to be seen only when they are controlled, stable, medication tolerated, no significant side effects, questions answered, then we can do the 3 months thing. So unfortunately and unintentionally, obviously, I'm not accusing any physician. Sometimes we let go of this. There is nothing called 3 months till the blood pressure is controlled. There is nothing called 3 months till the heart failure is controlled, till lipid control, till diabetes control. This needs to be. Now, diabetes may be slightly different in some aspects, but the concept stays the same.
And virtual encounters can also be built into the system very efficiently in terms of your time. Yani if it's just blood pressure monitoring or home blood pressure monitoring. We have to use, I think Dr. Abdullah has mentioned this, digital tools, and as you've very kindly mentioned, AI tools to predict people who are going to be non-compliant even. And there's a lot of automation that you are sort of leading this in the country and worldwide. Yani you know that we have a lot of automation that can be derived from industry that can help a lot of patients and even help the healthcare system develop and find the non-compliant or the missing patients.
Our number one challenge is obviously data security and the ability to access the data in a program that is multidisciplinary, but it's moving in the right direction.
طيب. So I think, the attendees here, heard lots of theories, but I think tonight was more practical. That's why I wanted, both of the speakers here are into the field. I know they are expert academic, but they are both very practical. You heard, I call it this is the the tricks of how to detect early, intensify, and follow up, to the extent that Dr. Summer says, it's unethical. Remember, so really, if it's not coming from your system, please bring the patient back, see them early. Is benefit for you and for the patients, because you are that patient, give you a nice dua, inshallah. Then because the blood pressure stay controlled, and you prevent what already said, the atrial fibrillation, the heart failure, the stroke, and so on. And then, and instead of patient end up with another problem, having a stroke or having another lots of polypharmacy. And you heard the adherence is important. How to simplify the medication from start. I think that's very important. We think antibiotics, sometimes we don't finish it in 7 days. So try to simplify the medication and try to use the medication which have synergy. There are lots of combination, but there are medication really which is give you to the target and stay on target and really protect the heart. And remember, the medication for when it comes atrial fibrillation, NOACs. I know there are some of them are very common, but there are certain patient needs certain NOACs to prevent the bleeding, and don't underdose, please. And if you are afraid, give it to your colleague, ask your colleague, because we should not because of limit ourselves. Things are available, resources available in the country. We try to control and reduce the cardiovascular together. I think tonight meeting was about a disease, or I can say one thing, a journey. A journey. If we don't do it properly, end up with the event. And unfortunately, we as a cardiologist normally see the patient at the end. But alhamdulillah, now we are moving to the beginning, because to prevent things happening, and that's the job of Dr. Samber beautifully said, how to control blood pressure, how to start early, intensify, right medication, adherence, using the digital, and then the AI, of course, inshallah, we'll hear more about that. And Dr. Hani beautifully took us through the NOACs and the patient phenotype, and then follow up is important. So both of you, thank you very much, really, for your great effort and input, and thank the MPC for making this possible. And I think the organizer here, the ICOM, asking you to do the evaluation so you can get the certificate maybe in 2 or 3 weeks from the DHA. So thank you both again.
Thank you for an amazing moderator and an engaging chairperson. Thank you. Thank you, Hani. Fly back home safely.
Abdullah.
By the way,
Thank you.
I allowed the
Yes,
AI to do a little bit more. It kept more thinking, and it came up with finally the same answer. Apixaban 2.5 is not correct, and for the dabigatran 150 using lower aspirin. But it took it a long time, and I had to redirect it. I told them,
mashallah.
I
You,
actually had to give
you
it.
reprogrammed the AI, mashallah.
Yeah, we just have to tell it the right question. So remember, our colleagues really should learn how to work with this AI.
Dr. Shahab, can I say something before we go? So to answer my dearest friend, actually both of you are dearest friend. I always give the example to put a smile before we end on AI. So data, I'm gonna make a salad with Dr. Shahab and Dr. Hani Sabur. The data is the constituent of the salad. So we need a good lettuce, good tomato, good lemon, etc. If the data is messed up, it doesn't work well. Now, the algorithm, al-Khwarizmi, is the recipe. So the recipe is also very important, and you need to know how the AI is done. So the more you know how the AI is done, it helps a lot. And then the outcome is the salad. So it's the recipe that's usually a big challenge, and the data. If the data is proper, here it was, we need to go back to the recipe. So remember, algorithm is the recipe of the salad. And thank you very much.
Thank you. Good night. Assalamu alaikum.
Awesome.